Welcome back. As we get ready for the next session, I was trying to acknowledge at the end, I want to make clear that this was a group effort, that we had some terrific guidance by a leadership team that put together the program, Ashisha Treja, Deborah McGinnis, Joel Dudley, Kumar Chaitanya. You'll be hearing from each of them more during the subsequent sessions. So now it's my pleasure to introduce Burton Drayer, who's the chairman of Radiology and the director of our faculty practice, obviously a leading thought leader in radiology and technology, and he'll in turn introduce our next keynote speaker. Bert.
Thank you, Scott. It's truly a pleasure to introduce our next speaker, Dr. Gregory Sorensen. He's a physician, he's an innovator, and a friend. He's a graduate of California Institute of Technology, and then he received his master's in computer science at Brigham Young, and then went on to Harvard Medical School. He remained at Harvard for many years, where he was a professor of radiology and also of health sciences and technology at both Harvard and at Massachusetts Institute of Technology. And he was the co-director of the prestigious A. Martino Center for Biomedical Imaging at Massachusetts General Hospital. Greg's a world-renowned leader in the clinical and translational research applications of neuroradiology. His research has provided the fundamental basis for numerous clinical trials in stroke and neuro-oncology. And because of his unique standing in the radiology community and his exceptional communication and innovation skills, he served for 4 years as president and chief executive officer of Siemens Healthcare North America. You know, when you introduce someone talking about innovation, I feel so old-fashioned because it's a standard introduction. I think the essence of Greg is his ability to change, his ability to innovate, his ability to not accept what is the accepted norm, and to keep moving on and looking at how to do something in a slightly different way and always in a better way. Once again, it's a privilege to introduce our next speaker, Dr. Gregory Sorensen. His topic is Innovations in Medical Imaging, Cash Cow or Cooked Goose. Greg.
Thanks so much, Bert. That was a very kind introduction, too kind. It's a real pleasure to be here with you. And I suppose if I were going to make a subtitle for this, it would be that the guy from Jeopardy who said, "I, for one, welcome our computer overlords," because I think that's coming to our future. And so it's great to be here and to have a chance to talk with you about medical innovations and especially digital medicine. When I moved from the academy to the business world, I learned that often in communication we don't use any slides at all. And I'm not sure exactly why that is, whether business people have either a different attention span or what. But I did get into a kind of a rhythm of storytelling in some of my talks. And so I wanted to begin by showing you kind of an outline of the story that I want to tell you, which kind of starts out with me describing a situation. Then, like all good stories, there's a complication before we finally get to the resolution. So the situation I actually want to talk to you about to try to bring into focus the ways that you can make a contribution is not to talk about all the medical problems or the list of top burden of disease that you might find on the WHO website, although I like and respect all those. I thought today, because of where we are, especially here in New York City, that I would talk about a substantial problem you may not be aware of, which is productivity in healthcare. Productivity in healthcare is actually abysmal. And I'm going to show you some data about that. And I want to talk to you about how technology, and especially digital technology, might be able to help resolve that. The complication is going to be us doctors, because we're particularly, my thesis is, incredibly hostile to technology. Despite what you've seen today so far and the deluge of things that seem to be happening, I think if you were to examine yourself, if you're a physician, or if you were to look around, you'd see that there's actually subtle and not so subtle ways in which physicians really push back against technical innovation in their practices. It's interesting. So that's the story, and then I'm going to give you some resolution with some ideas. All right? So let's begin, actually. Let me dive right in with the productivity problem. Data. Data help illustrate this. This is a graph of change in productivity on the y-axis versus how baseline efficient an industry is. And I've got data from the Bureau of Labor Statistics, the National Center, the United States Department, that has plotted out various industries. And I'm going to show you how this changes over time. And so you can just kind of watch the green dots here as we fast forward. This is a baseline at 2002, and from 2002 to 2005, how much there was change. Now to 2006, to 2007, 8, 9, 10, 11, and through 2012 is where you have the data. And so during that roughly 10-year period, you can see that healthcare actually did change its productivity, but it changed it negatively. We got less productive, even though we were making more work. So more work is the y-axis, so there's more output, more people employed in healthcare. How much are they actually generating? How much work efficiency is there? That's going down. And what I found fascinating about this graph when I was first studying it was top right, information technology. Yeah, you can kind of get that. We all see that there's Moore's Law, all the stuff we've seen earlier this morning about the fascinating advances in informatics. And I can kind of get manufacturing. Where I worked for 4.5 years, Siemens, we're a big manufacturing company. I get how that innovation is really driving that efficiency. What was shocking to me was to see that we were doing worse than farming. Until, of course, I spent some time on a farm. And when you spend a time on a farm now, what you see is farmers sitting in their tractors with a smartphone and the GPS driving the tractors around. What you don't see is very much of that happening in medicine. And you see probably one of the few groups that we've done worse than is mining. And the reason the miners claim that they've gotten life has gotten worse for them is all of the easy gold has been mined. Now they have to do the easy strip mining. The stuff near the surface was easy. Now they have to work a lot harder to get the same amount of effort, coal or gold or silver or whatever. So whether you believe me or whether you don't believe me, these are the data. These are well scrutinized. And I think it's pretty clear that we do have a problem in healthcare, that we are not as productive as other industries. Notice that education, something we're doing here today, is also less productive over time. And I think those of us who've spent time in universities have seen that the expense of university, the amount of people working in universities has gone up, has the educational output, the fundamental core, not necessarily gone up as much. So, basic situation here, productivity lags. And this lag happens at a bad time because, as you know, in the United States, this is almost another talk of mine, the United States cost curve is in trouble. It's much worse than other countries. It's much worse than it needs to be. And had our productivity in healthcare been the same productivity that we had seen, say, in the average of those earlier graphs, then we would have saved $1 trillion over the last decade in healthcare expenditures. And if we were as good as manufacturing, we would have saved 40% compared to where we are today. Now, you might say to yourself, why is this? Why is healthcare so bad at the productivity thing? How come? And really, this is just sort of an illustration that I'm using to try to get you to think about all of these innovations that you're seeing. How do you rank them? Which ones are important? Which ones should you focus on? Which ones should you delay later? Or if you prefer this mode of thinking, which one can I make a lot of money in versus not? And the answer to that is, how can I improve output, value in medicine with less effort? Now, before we dive into some of those answers, it's actually useful for me to bring up one other complication, which is that physicians, and medicine in particular, have a structural problem. This was a structural problem that an economist, a British economist by the name of Baumol, described a few decades ago. He actually called it a cost disease. And the easiest explanation for this is the string quartet. Economists love this example. I love this example because it's pretty easy to grasp quickly. Think about the productivity of coal miners, for example, or the productivity of transportation, and you can see how information technology has radically changed out in the last, say, two centuries. Transportation, we can move much faster because of machines, and if you think about clothing, the looms and all these other technical innovations have grown, have made our costs much lower for the same goods and services. However, contrast that to the string quartet. The number of people and the amount of time it takes to produce a 4-minute Mozart string quartet is almost exactly the same as it was 300 years ago. 300 years ago, it took 4 people 4 minutes to produce 1 string quartet. Today, it takes 4 people about that same 3 minutes to produce a string quartet. No increase in their productivity. And Baumol noticed that there were certain parts of the economy that are just structurally set up to not be amenable to technical innovations, to doing things in a way that technology can leverage. Unlike plucking cotton or harvesting grain or analyzing data, machines can't really play the string quartet any more efficiently. They don't really help us with that. So he called that a disease, and he said there were certain kinds of parts of the economy that had this disease. And you can imagine that medicine is a little bit like that. If you're a nurse, seeing 100 patients an hour instead of 5 patients an hour probably isn't a good idea. You're not really being an effective nurse, and same being a physician. If you want to do a surgery and it takes an hour to do that surgery, maybe you can get that down to 50 minutes or 45 minutes through some real technical innovations, but in fact, it just takes some time to do certain things like playing a string quartet. Now, of course, we know that the cost of consuming a string quartet has gone down substantially because we can record them now. We can put them onto our iPods. We can put them on Walkman. We can distribute them electronically. And so consuming a string quartet actually has gone down a lot less, but producing is about the same as it was. So we have a productivity problem. We now combine that with we have kind of this structural problem, and you see that we're in a particularly challenging mode. And it's in now to try to break that conflict or that complication in that situation that I'd like to talk to you about some innovations that I think could be the most valuable to help resolve these. And because of today's theme, I thought I would specifically focus on areas of digital medicine. So let me highlight a few for you now that I've kind of set up the problem. One of these themes, I think there are 3 that I want to talk about. One of these themes, the first one I want to talk about is industrialization. I think healthcare is very much under-industrialized. And I'll show you a little bit of data, but I think, again, your own experience can convince you of this. This is some data that I grabbed from our own systems at Siemens. This was some installed base MRI scanners on the left, CT scanners on the right, and the histogram is how much they're used per year. And any industrial expert would tell you, a productivity expert, would tell you that whenever you see a curve that broad, you are not utilizing your resources effectively. That effective factory utilization is when there is a very narrow range of variability, and you've optimized things, and essentially variability is a marker for inefficiency. And I think this is really impressive inefficiency. We have some, I don't know if you can read that are at almost 0, but certainly less than 100 exams for the whole year for an MRI scanner. And we know this because they're connected to our service devices. So we can tell based on, the kind of how many times the machine is run, that in some installations there is, really less than 100 per year. And in other places, there's over 7,000 scans per year on an MRI scanner. Same thing with CT, it's even more dramatic. There's some up there, you can see almost at 30,000 scans per year, and some down at close to 0. Now, I actually showed this to one department chairman of his specific department, and he said, oh yeah, that 0 one in the MRI scanner, I know that one. That's the one that pediatric guy insisted that we put in the children's hospital, and it only gets used, once or twice a week, but it was special purpose, and that's what we needed it for. So there are some almost understandable reasons for some of these variations. But I think in general, we have an opportunity in medicine to become much more industrially focused. Physicians hate that. Hence, you get the first beginnings of my hints about how physicians are actually the problem for a lot of what's going on in medicine today. They don't like the idea of industrialization. They resist that. They feel like it makes the patients and their interaction less. Nevertheless, when you see data like this, it suggests that we have a real challenge. We have a challenge not only in utilization of machines, but in the performance of some of our caregivers. So this is data that we collected at Siemens when we were submitting our newest breast imaging device, a 3D mammogram device. It's called Tomosynthesis. the FDA insisted that we compare how the new device worked to the old device. The old device was a standard mammogram, 2 directions. The new device does over 25 directions and then synthesizes that into a single image. And so it's, what do you know, better. And the question was, well, how much better? And so we hired 22 what we thought were good radiologists and gave them the 2D version and then the 3D version and measured their performance using receiver operating characteristic curves. That's ROC, and this is the area under that curve. It's like accuracy, more or less. And you can see that there's a big improvement when you give people the 3D tool. And in fact, it is true that and this is pretty well documented from other studies and other manufacturers, that when you get the 3D mammogram, you're more accurate in detecting breast cancer. And these were all in validated cases where we knew what the outcome was because we had a year follow-up and so on. The reason I'm showing you this graph, though, isn't to talk about the technology per se. It's to show you the variability in the physician performance. Especially look at the blue lines on the left. There are physicians out there who we thought were actually pretty good physicians, board certified, routinely practicing, with areas under the curve of their ROC curve in the 0.65 range. Now, if you know ROC curves, you know that 0.5 is a coin toss. So we're not doing a whole lot better than that. And there are a number of physicians, many of you may have met them in your own practice, who are not performing all that well. Now, that's common in most areas of human endeavor. What's uncommon about medicine is how rarely we measure this and how averse we are to working on it, attacking the problem. This is at the core of industrialization, and if you could find a way to get physicians to do this painlessly, or at least willingly, you could really boost the productivity and the care of patients in a way that really needs to be done and that would provide tremendous value. So another idea around industrialization, or problem. A third idea that I'm going to finish with on industrialization just was really provoked by the report last month from the Institute of Medicine on improving diagnosis in healthcare. I don't know if you had a chance to see this report, groundbreaking. It's another one in this series of To Err is Human, very important, talking about diagnostic error. Maybe you know this, maybe you don't, but when you rank order all the mistakes we make in medicine, the most expensive error we make, the most frequent error we make, the most deadly error we make, type of error we make, it's all the same type of error. It's diagnostic error. And if you haven't read this report, let me just share with you one of the many anecdotes that's just heartbreaking. This is about a real family, Sue, Cal, and Pat. They didn't put their last names in the report, but let me just kind of bullet through this with you quickly. Cal's the baby, born to Sue in a large hospital. Shortly after, Cal develops jaundice. 36 hours later, he's full body, yellow, deep jaundice. Nobody measures a bilirubin at the hospital. He's discharged to home with reassurance that this happens, don't worry about it. 4 days later, he's even more yellow, lethargic. They visit his pediatrician, again, reassurance, no bilirubin test done. Finally, the parents insist on the kid getting admitted. The parents then tell the staff at the hospital during the course of admission that they're seeing worrisome behaviors, the arching, respiratory distress. This is basically ignored by the staff. Finally, and again, they're basically told not to worry, don't take action, we'll watch the baby. Finally, they realize something's going on, but by then, brain damage has set in. The bilirubin is too high. And now at age 20, significant cerebral palsy due to this. Truly tragic, classic misdiagnosis problem, easily corrected, didn't happen. This is repeated throughout hospitals all around the country, and I'm afraid all around the city, day in and day out. Same family, a couple of years later, husband now, Sue's husband Pat, has progressive neck pain. He gets a scan. MRI shows that he has a mass in his cervical spine. Time of surgery, the neurosurgeon sends off some tissue to the pathology. Pathology calls back and says this is an atypical spindle cell neoplasm. So the surgical team assumes this is benign. They complete the surgery. They tell Pat he's cured, send him home. Later, the path stains showed that this is actually a malignant synovial cell sarcoma. The path report gets sent to the neurosurgeon 3 weeks later, never gets seen by the neurosurgeon, somehow misfiled. The patient never gets word of this change of diagnosis. His local caregivers never get word of this. He recurs at 6 months with cancer in his neck. Despite 7 more surgeries, radiation, and chemo, he ends up dying at 2 years later, leaving 2 small children. one family, series after series of misdiagnosis. And what this encapsulates is that misdiagnosis isn't just forgetting to order a test. It's the communication problem, it's listening, it's diagnostic thinking. This is a huge opportunity for improvement in medicine that technology could help us with. We know in other areas of our endeavor, of our economic endeavor, how to bring IT support for these kinds of things. And they're welcomed, or at least used. For some reason in medicine, this kind of assistance is actively opposed by many providers. Industrialization is still happening, though. And it's happening in part because, frankly, a reason that gives me quite a bit of hope, and that is the millennial generation. Many of you may or may not be aware that, especially outside of New York City, there are a number of large firms that are hiring physicians, and physicians are happily going to work for these large firms. This was one in radiology, a company called Mednax, already a $2 billion a year medical staffing company that hires physicians. I've listed on the right a few other large companies, MCare, Team Health. These are multi-billion-dollar a year companies that are hiring physicians. The physicians don't work for the hospitals. They work for these companies who then contract with the hospitals. And one of the key reasons for that there's value creation here is these companies are better at the industrialization process. They're better at training their docs. They're better at these kinds of reminder and IT-assisted tools that you need an IT infrastructure for. But also because of today's millennial generation, there's a different work-life balance of interest. Many younger physicians are willing to take a little bit less money in exchange for more control of their life. I have a friend who's an intensivist. He likes to work 8 days, and then he has 20 days off. That's just his style. It works well for his life. He has 8 very busy days, and then he doesn't for 2 weeks or 3 weeks, and then he writes and does other things. And there are now all kinds of subspecialists. There, of course, are classic hospitalists and intensivists, but there are now surgicalists. In fact, there are even deliveryists who all they do is deliver babies day in and day out. And there's actually pretty good evidence that this improves the quality of care, as long as the handoff is handled well, and that handoff requires information technology and acceptance of that information technology. And so industrialization, breaking procedures down into smaller and smaller pieces so you can optimize them. This is the classic piece of industrialization that happened a century ago in other parts of our economy. Many parts of the medical practice are resisting that, but information technology can enable that and reduce the friction and improve the coordination. Now, I did like what the earlier discussant talked about, if I were going to bring up a second point, virtual reality. Here, unlike the first industrialization, I'm less sure about how virtual reality will make a big difference. It's harder for me to see. I do like these kinds of toys. If you haven't had a chance to play with a virtual reality set, it's definitely worth doing. It's not necessary for you to spend the $300 to buy an Oculus Rift device. If you have not spent the $16 to buy, or $10 now, to buy a Google Cardboard and put it together and put your smartphone in the front, please do so. It's a great gift if you have grandkids or kids or teenage friends. But if you haven't, it's really remarkable what $10 worth of lenses and technology and paper, very low technology, added to your smartphone can do. This really is going to change the way we learn medicine for sure. Some of these errors can be reduced through practice, and virtual reality, like with Google Cardboard, really is remarkable. And if you haven't tried it, it's worth trying. I don't know if we'll get to this kind of a situation yet, where everybody around us looks beautiful. We can hope that virtual reality will make our lives better. But I think as physicians and as practitioners, it can really make a difference. How that will actually happen, I think, remains to be seen. There's a lot of opportunity there. The third thing, and then I'm going to finish, and hopefully we'll have time for a question or two, that I really wanted to highlight to you is a breakthrough in artificial intelligence that goes under the rubric deep learning. As Bert said, I studied computer science maybe 30 years ago and really worked hard at trying to figure out how machine vision could work. And at the time, we used algorithms that came to be known as neural networks. They were essentially equations that were patterned and modeled after the idea of individual neurons connecting with each other and using synapses to weight the variables in the equations differently. And that's basically what's at the essence of deep learning. Deep learning, if you were to sort of think about it, it's really a reincarnation or a reuse of those old artificial neural networks. The difference is that instead of having computing power that can compute, say, 100 synapses or 1,000 synapses, now we have computers that can train 10 million synapses, or little variables in this equation. So if you oversimplify what deep learning is, you can think of it as a very sophisticated box with, say, 5 million knobs on it. And if you wanted to recognize a dog, you put a picture of a dog in front of it, and if the light goes green for as dog, then you say, great. If it's red, then you turn some knobs until it says goes green. And then you pick another picture of the dog, and you put literally tens of thousands of pictures of, say, a dog, and you can then adjust those knobs so that it's very good at distinguishing dog from non-dog, or dog from cat. And this actually is the essence of the algorithm that's behind Google Photos. If you've bothered to upload your own photo library to Google Photos, you can actually do that and then type in Grand Canyon, and it will find all of your pictures of the Grand Canyon. Or woman, and it will find all the pictures of a woman, or beach, and it will find all your pictures of a beach. And it's because this algorithmic approach has improved so that we can, by seeing lots and lots of pictures, that's the deep in deep learning. And really what's surprising about that is this actually does seem to be working. And it surprised me because I'd studied this 3 years ago and it didn't work then. And the breakthrough has really been that we have computing systems that can tackle much larger equation systems, so like I said, millions of variables, and we now have tens of thousands of pictures of dogs, something that was actually very hard to get 30 years ago. It was really hard to get digital pictures. It was hard to store them. It was hard to obtain them. Now, all of you on your phones have probably more pictures of dogs than you're willing to admit publicly, but those are out there, and so you can train these algorithms in ways. And so, in fact, one of the key ways that this is now being advanced, one of the interesting sort of side phenomenons, is that deep learning is still a very academic community. A lot of the folks who are doing the best work in deep learning work for Facebook or for Google or for Baidu or for Microsoft, but they're academics at heart, and they like publishing and talking, and they like competing. And one of the ways they compete is with something called Imagenet. Imagenet is actually a public database of images. Actually, as you can see, 14 plus million images of all kinds of things. This is the word graph from their website that shows the kinds of images they have. And they've basically come up with an algorithm that when you test your new trained data set, you get a subset of those 14 million images, but you never get to see all of them. And it prevents overtraining. So you might be able to test 1,000 at a time, but you don't get to see the other 14 million so that we don't overdetermine the solution. And that allows the field to advance by doing that comparison against kind of a safe, if you will, standard. Now, we need that in medicine. Because, in fact, as you heard earlier, there are some companies, like a company called Metamind from this slide, who are doing things, as you heard one of the panelists say earlier, training systems to interpret or at least scan pictures, radiological pictures, to detect things like brain hemorrhage or retinal problems or lung nodules. But they don't have those 14 million images. Now, some speculate that that's why IBM paid $1 billion for Merge Technologies last month, because Merge is basically a PACS system that has billions of images in it. On the other hand, there are some of us who think that's a little bit like buying the Golden Gate Bridge and thinking that you now own every car that drives across it. Just because you own the PACS system doesn't mean you own the images. But nonetheless, the point here is there's billions of dollars of value to be unlocked from these medical images because we need to train those algorithms. How to train them, and then back to my cultural problem with physicians, how to do that in a way that physicians accept and want that learning and those assistants. There's a lot of value to be unlocked there as well. All right, so that's, I think, where I want to try to wind up. This is my last slide. I talked to you about our productivity problem. I kind of started that abruptly. Sorry if that was a little jarring after the break, but it's a real issue. Productivity is still lagging in healthcare. We have particular resistance from physicians, Part of it is because of this structural problem, like string quartets. We just can't rush certain things in our human interactions. But part of it, I think, is more than that structural problem. And I offered you some ideas about how to overcome that, especially the idea of industrialization. I think there's a lot of ground to be gained there, but I also think there's plenty of interesting things to do with deep learning and combining deep learning with other forms of artificial intelligence. Deep learning is just one type. It will never solve certain kinds of medical problems, like in radiology, we talk about Ant Minis. You'll never be able to teach a computer to do Ant Mini-like reading with deep learning, but there are ways of combining deep learning with other kinds of learning that I think will bring the computers to assist us and maybe even surpass us as physicians. And so with that, I'll thank you for your attention, and maybe we have time for a question or two. Thanks so much.
So, Greg, if you want to stay around, we do have microphones here. I don't see any questions on the iPad.
Stunned silence?
Stunned silence.
Yes. Come on.
Hi, I'm an undergrad student, and I want to say thank you for mentioning the millennials, first of all. So basically, I was really upset about the fact that they didn't ask about whether any undergrad students were in the audience today. But I wanted to ask you about whether or not you think the idea of microdata or tiny data could be used with thin slicing and as well as some of the technologies that you mentioned in an effort to kind of use computers but also technology to form the optimal question but also the answer that we wouldn't be able to, I guess, pinpoint in that situation.
Yeah, sure. So I do think that the sources of data are rich, as we heard earlier in the morning. I think the thing to make sure you're not confused by, though, is lots of data from one person is not the same thing as a little bit of data from lots of people. And it's, if you study one case of cancer with lots and lots of genomic information and lots of characterization, lots of phenotyping, that doesn't let you necessarily generalize to other kinds of cancers. It's just the nature of the biological variability that is life. That's not to say, though, that that microanalysis, if you will, or the very intensive phenotyping of people couldn't have and won't have a lot of value. I think we don't yet know precisely what it is, if, for example, in measuring somebody's heart rate constantly, that will be valuable. I remember learning years ago that it's not necessarily the rate, but the variability in the rate that can sometimes be predictive. And unless you get a lot of that kind of data, you're not going to be able to extract those kinds of new insights. So I think it will come from a combination of this plethora of information gathering devices that we have, but also some new thoughts, hopefully from you young millennial people, about how to leverage this kind of technology. Very powerful, but it does desperately need some new insights. But I am convinced that there's a lot of value to be created. I mean, if you step back and take the VC look at this, basically there's $3 trillion a year being spent on healthcare in the United States every year. Most people think 800 million of that is wasted. Somebody's going to make $3 trillion, 800 billion being wasted. Somebody's going to make a couple hundred billion figuring out how to save that 800 billion, right? So if you can do that, you're going to make a lot of money helping the system get a lot better. The other thing I would just say is I hope those devices can help improve care, because as I traveled extensively, much more than I did before when I was an academic, saw lots of parts of America that I had never become familiar with, there is actually a lot of bad medicine out there. It's kind of disappointing, but there are a lot of parts of the world where the thirst for knowledge and the thirst for excellence isn't as strong as it is here at this strong academic institution. And we don't, rather than just rant against that, let's help those people by giving them tools that help make it easier for them to do their job and to do it well, and take the advances that you're making and diffuse those out into medicine. Okay, I think I've used up my time, right?
I've got one final question.
Yes.
One quick question. You talk about industrialization, and we talk about personalizing medicine.
Yes.
This human interaction is one of the pieces that we call ourselves physicians and patients. How can you industrialize this whole communications between patient and physicians?
I think it's an
can't
excellent question. Yeah, and I don't mean to minimize the challenge thereof. However, I do think that there are industries where people feel like they're getting more personalized attention even while the efficiencies of the industrial world come together. So I could give you one quick German example. If you go to BMW's website, you can order your own car that is specific for you. Millions of options, seats, wheels, steering wheel height, all that stuff. And you customize it. It feels like your own. It's just for you. And yet, that's become very, very efficient. And it's harder to do with people, no question, but the opportunity is there, whether it's quickly connecting to, my sister-in-law right now has, unfortunately, at age 37, stage 4 lung cancer. Finding the right physician for a 37-year-old stage 4 lung cancer, that's a personalized medicine problem. IT has got to help me figure out how to do that. Right now, the system is she goes to her local hospital and she sees who she sees. That can't be the best way to personalize medicine. And industrialization would fix that. It would optimally match people with the resources they need. That's an industrialization step that I think would vastly improve personalization of medicine. Thanks. Great. Thank you.
That was great.